Hello, I'm Frédéric Padilla. I'm the director for applied physics research at the foundation. I will be leading this next discussion about the immune effect by tumor type. So we already approached these questions in the previous session. And what we would like to do here is to try really to frame the discussion again around tumor types. Is there specific immune effects after ultrasound treatment that can be created or in different across tumor types? Is there a specific tumor type that would be more sensitive to different types of focus ultrasound? So, for example, can we classify cold versus hot type of tumor as better responder to a combination of focus ultrasound or immunotherapy? So this is this kind of question that we would like to discuss. So I would like to start by opening the discussion maybe to the public if there are specific questions to the speakers. I mean, some of you, Tatiana and another, gave an overview of immune effects or specific immune effect by first modalities over different tumor types. So do you have any open question that we would like to address? No? So if not, maybe I'd like to start maybe with a general question about brain tumor versus other type of tumor. So is there a specific, do you think, are there very specific response to brain tumors that are not found in other type of tumors? So
I don't know that I have an answer for that at all, but just as a comment, one way that we could possibly think about that is try to kind of separate the brain microenvironment from the tumor itself. And rather than looking at, say, a GBM model, look at a metastatic melanoma model where we know how those tumors respond outside of the brain to focus ultrasound, and then look at how they respond when they're within the brain microenvironment and how that changes things to give us a better idea of the utility of focus ultrasound for brain tumors in general.
So do we think that a specific microenvironment would be more amenable to focus ultrasound treatment, for example, in terms of PD-1 or PD-L1 expression or infiltration of CD8 T cell or immunosuppressive microenvironment? So what do you think? Is there a specific microenvironment that we should target with focus ultrasound?
Is this a general question? I'm sorry, I ran out for a cup of coffee.
Yeah, no, it's a short
missed the introduction. Is a general question. So I mean, there's two contexts where focused ultrasound can be deployed, right? You've got the initial context where you're trying to initiate that the immune response that is going to then be propagated as a consequence of an immunotherapeutic intervention. So that would be a classic case, there would be checkpoint. But there are other instances, and then you've got the patients who are not responsive to checkpoint, or the disease types who are not responsive to checkpoint. And there is two contexts for that. We have primary resistance, which is the cold tumor, then the adaptive resistance, which is really the loss of response to checkpoint. And those are two very, very different contexts. And we talk about using focused ultrasound writ large, and when should we best deploy it? But I think we need to be much more cagey about that context of the presentation of the patient, the prior therapies that they've had, and successes and failures of those therapies. And it ultimately goes back to the immune landscape. What is the basis for, shall we say, the adaptive resistance? Was it a loss of an antigen? Was it the recruitment of a myeloid cell population? Was it some sort of vascularization effect that changed? And so it goes back to Rich's point earlier about precision medicine, that we're going to have to understand the basis of the patient's lack of response to whichever therapy, and what is the best type of focused ultrasound that could potentially bridge that pathway to successful treatment of that patient. So I'm a little skeptical of broad brushstrokes when we talk about focused ultrasound. And I mean, and I think a case in point is, and we would criticize our mouse models intensely for good reasons, but there are many instances where we will see in a syngeneic mouse model with a genetically identical mouse with a genetically identical tumor, and you'll see half the mice responding to it. And it's very similar to some clinical trials, right? You'll see some patients respond, but the majority not. And we learn a lot by studying the patients who respond and patients who don't. So I think if we take that approach to looking at the focused ultrasound delivery, I mean, I'm touching on a lot of topics here, but if you look at the failures and successes within any cohort of a mouse study, that can be quite revelationary in terms of what has that particular modality of focused ultrasound improved upon. Right? And I think that's what you're really asking is, how do we select which focused ultrasound? Is we need to know how it's actually improved something. And the failures and successes of any study need to be embraced there and published, quite honestly. I mean, it's really difficult to support, many instances, it's difficult to publish when things were not successful, or if you have a half a mouse population responding or not. A lot of reviewers were like, well, your statistical significance is not there. And I'd say, well, true. But if we look at the cohort as a whole, we've had some very good responders. And I think that's an important prism to be looking at this with.
Good. Oui. Dr. Koklova, Tatiana?
Yeah, those are all great points. And I think I'd also add that in terms of wide brush strokes, that it really should be kind of tumor specific, I guess we should build on things that we know. And in some cases, I mean, immune checkpoints have been in clinical practice for some cancers for quite a while now. And there has been a lot published, and I don't know if there is consensus yet of, okay, for example, for melanoma, which patients do respond, which tumor microenvironment aspect determines whether the patients do respond to checkpoint inhibition or not. So, because that field is so much more mature, if we don't know that, even for that, how can we sort of predict something or definitively say what focused ultrasound will do if even the other treatment modality that we'll build on top of is not yet brought to consensus? And maybe there are, for example, infiltration of CD8 T cells, I think, is into the tumor, I think correlates in a few cancer types clinically with success or failure of PD-1, for example, therapy or other checkpoint inhibitors. But for example, response to gemcitabine in pancreas, in pancreatic cancer, there's a lot of theories out there why some people respond and some don't. There's CD8 T cells there in some cases and not others. Does seem to correlate with good outcomes, but not always. So I think it would be, by tumor type, it would be great to have sort of a consensus of sort of current therapies of where do they fail exactly, if that's known.
Yeah. We will have this discussion again tomorrow about the biomarkers and what should we measure, and so we can defer to that. And Dr. Avanatis Kostas.
Hi, everybody. I think it's very, very useful and informative conversation. I totally agree with what Tanya mentioned. I'd just like also to go back to the a question that Kelsey asked about what tumors are important and whether we can convert cold and hot tumor, convert cold tumors to hot tumors, and whether we can study some tumors in the primary metastatic setting. I think as far as brain tumors is concerned, and we've been working in that field for some time, I think the challenge is therapeutic trafficking, and the challenge is clear there. So can we use ultrasound to improve therapeutic trafficking? So this is, we know that, for example, pancreas, I don't know about pancreas, for example, I know about breast. So patients that have breast-brain metastasis, even if you cure the primary breast, when the tumor metastasizes in the brain, the chances of survival are quite slim. So certainly the tumor microenvironment plays a role, but also this suggests that treatment that might be effective in the primary site might not be effective in the brain, for example. And one of the main reasons is the challenges that we have in order to achieve sufficient or robust therapeutic trafficking. I think that's a clear goal. If we are able to overcome this barrier and identify methods that will improve therapeutic trafficking, that will be a major milestone. So if this can be achieved, I think the second milestone will be, can we identify ways to support cytotoxic activity? So if we solve the trafficking, therefore means we have sufficient, whatever drug this might be, cell or a molecule, we know that it is in the brain. And then we can ask the question, is it functioning as it's supposed to function, or we need to do something else to support its cytotoxic activity, in other ways, overcome resistant mechanisms. So there are two clear and distinct, I think, challenges there that could, of course, this is in the context of immunotherapy, supporting immunotherapy, not like using ultrasound to promote, endogenous responses and adaptive immunity. So I think in that context, there are clear challenges there, especially as far as brain cancer is concerned.
Mm-hmm. Thanks, Asa. Dr. Ranjan?
Yeah, when it comes to activating the anti-tumor immunity, a question that we can also ask is cure a goal or is control of disease a goal? Because when we do my studies, sometimes the activation of immune system could be optimal to give a relatively better control compared to untreated controls, but it may not always give a cure rate, especially if we're doing investigations that involve understanding abscopal effect, which is treating a primary tumor to see how untreated tumors behave when an immune system gets activated. So it's something that could be developed as an agreement also in the field that while cure rates are ideal goal, even in the mouse setting, it may not always be possible. So how to define an immune effect that is a good immune effect, even when we are not seeing huge regressions, but we are seeing a control of disease, could be something that could be brought as a thought of it working and not working.
So to go on this field, again, it's something we will also discuss tomorrow, but is there a set of specific markers or parameters that you think should be measured across tumors, a basic set of response indicators in terms of infiltration or specific cytokine expression that we should be looking at in this context?
Yeah, I think at least in our analysis, what we are focusing on is not just on the number of immune cells that get infiltrated in the tumors, but their functional status. So for example, if you're looking at T cells, do they co-express granzyme B or interferon gamma? And if we have more of those functional immune cells, not just immune cells, for us, those would be a good biomarker. Likewise, we can look at the cytokine level. I would be curious to know how other research groups are looking at it, but it's the population of activated and functional immune cells that could be more crucial as a biomarker than just predicting that we have more of the immune cells, because sometimes they may be immunosuppressive in nature, even if there are more of it. So looking for a functional population of T cells or dendritic cells could be a good idea.
Mm-hmm. Mm-hmm. So I had one question. Oh, yes, Teresa, yes, please.
Yeah, I think the complexity, the hard part with immunotherapy is that it's not a biomarker. So I think we all agree T cells being in the tumor is important. But we actually have done a study where we looked with CRI, our Amadeus study, where we actually treated patients based on CD8 infiltrate to see if it was predictive. And we presented it at ASCO this last year, where if they had a high degree of CD8 infiltrate in the tumor biopsy, they were treated with nivolumab. We only had 7 of the hot tumors. It was an all-comer solid tumor study. And the cutoff was purposely high. So we didn't want anyone to say, is it 5%? Is it 10%? We did 15%. And nobody argues that that would be considered a high degree of infiltrate. Of those tumors, only 1 patient responded. And so to the point that maybe it's T cell fitness, and we're looking at things such as TCF7 and TOX. But then as we've looked in other studies, it really takes multi-omic, multi-parameter analysis to look at the overall immune fitness. So the dendritic cells matter, the antigen experienced T cells matter, the state of exhaustion matters, the cytokine profile matters. I mean, TGF beta signature across all of our studies is a very strong indicator of immune suppression and poor response. And, you know, we have angiogenesis signatures and interferon signatures, but when we put together based on the treatments, these multi-parameter analyses, we really get a picture of the immune state at baseline, and then see the mechanisms activated in responders or non-responders. And so I think the hard part here is to really get a sense of who to treat and how to treat. Is you need a cross-functional team that has experience to look at the differences in the T cell fitness and exhaustion. I mean, and the different cytokines. I mean, I feel like every day I'm learning a new CD number and what it means and how it relates. But when we put the whole picture together across multiple assays, we really did see consistency, whether it was dendritic cell activation or T cell fitness, depending upon the patient population. So I think that's the bad news is it's not simple. The good news is that I think with, you know, immune profiling, tumor, just RNA-seq, and whole exome sequencing and some basic immune panels, you can, and cytokine proteomic type profiling, as well as we've seen interesting data with microbiome, that you can get a good picture of the overall immune system.
So do you think that all this characterization of the immune system have to be included in a preclinical studies in order to be convincing for a clinical trial?
So I think from the preclinical models, I mean, it's a lot of the immune models do show when you put your spider plots together, responders and non-responders. So treating it like a participant and trying to look at what features happen, it can give you a sense. I mean, for example, we have seen translation of some of the preclinical data on different genetics translate with treatment. So when you see it happen preclinically and clinically, it strengthens it and it gives you a place to look. But I think it's really important in the clinical study to incorporate all of them.
Mm-hmm. Dr. Wu, you raised your hand. You want to?
Yeah, I think I would just want to echo the same points. The big problem with immunotherapy, it's all new. So if you say there is a validated biomarker, there isn't really one, you know, and everyone's trying to find the best biomarker, and that seems to be the problem. And so when you're trying to adapt that, a new technology or new therapy to focus ultrasound, you know, it isn't that simple. So then what is the approach? So I think the approach that people are doing, just broad stroke, is, you know, I think most people are looking at the expression of immune checkpoints as one, and tumor microenvironment, that's one approach. The other approach is looking at the types of infiltration, but not just in terms of T cells and whatever cells, but a lot of it's now going into, you know, spatial, spatial assessments to see what cells are next to what cells to predict potential interactions. And then obviously there's, you know, proteomics and sequencing that's going on. I think it's still a pretty big fishing expedition because it's just new. So I don't think there is one way to answer that. I think effective trials moving forward is the best next step is, again, probably in cancer where tissue is accessible in a reasonable risk manner, so that if you apply a fairly safe type of ultrasound with immunotherapy and you're able to assess tissue, your chances of getting information would be higher. So what that means is, like, for example, I treat kids with brain tumors. Clearly, that's not a great one to start with because you're not going to be able to do repeat biopsies in a safe manner. But say if it was skin cancer or something, whereas on the skin, you can see it, or metastatic something with an ulcerative tumor that's easily accessible, then clearly the ability to get tissue during the treatment would be higher. So there's things to think about.
Thank you. So if we go into a more specific tumor types, we had an interesting comment in the previous session about pancreatic cancer. So maybe Petros, if you want to comment on the specificity of, at least in a preclinical setting, specificity of pancreatic tumors response to therapeutic ultrasound.
Yeah, the preclinical data, we don't have that much preclinical data about pancreatic cancer and immunotherapy. But lately, over the past few months, some studies have started appearing on PubMed. It's a difficult model. It's a difficult model to test and do. And there are some evidence that HIFU can be combined with immune checkpoint inhibitors to provide some benefit. What has surprised me over the past few years working with this model is the efficacy of HIFU alone on pancreatic cancer. I think we were discussing earlier about which indication should we try HIFU in the clinic. And I really don't understand why we haven't tried HIFU in the clinic already in several trials. I can only assume it must be about its feasibility of using it in the clinic.
And we will discuss this clinical application in more detail this afternoon.
Yeah, in the preclinical models, HIFU works alone very well in not curing the disease, but delaying its growth, certainly. And I think if someone manages to do in a safe way multiple HIFU treatments, we will delay the progress of the disease considerably. And with immune checkpoint inhibitors as well, I think there can be a benefit there. We need to understand the correlation between how much mechanical dose we are giving to the tumors in order to have an effective immune response. And in order to combine it with the immune checkpoint inhibitors. It's another thing giving histotripsy with 30 megapascals of peak negative pressure. Another thing giving it a pulse HIFU with like 15 megapascals. Another thing going to low intensity focused ultrasound with like 2 or 3 or 1 megapascal of peak negative pressure. The biological effect is different. The destruction of the tumor is different. The amount of the destruction of the tumor is different. The method of action of how the HIFU works, of how the focused ultrasound works, will be different. And in terms of giving it too much inflammation, I don't think in pancreatic cancer we have such problems. I mean, B16 melanomas are so different than the pancreatic KPC model, than the pancreatic tumors. Maybe with B16, the basal levels of inflammation in B16 are already high. That thing we don't have with pancreatic cancer. We hardly have any inflammation with pancreatic cancer, but it is an open, it is a matter of discussion. The more we longitudinally, if there is fibrosis and inflammation developing in these tumors.
Tatiana?
So yeah, I completely agree with what Petra's shared. And just to add on top of that, so about HIFU alone. So we've been using pulsed HIFU to cavitation-based to promote penetration of chemotherapy. So it's sort of the drug delivery with gemcitabine lately. And interestingly, so it similarly to the brain, pancreas presents one common theme that there are barriers to penetration of anything. Immune checkpoints, chemo, you name it, which is part of why it is believed that most immunotherapies have failed in it. And so what we found sort of accidentally as we were trying repeated or weekly administrations of pulsed HIFU with gemcitabine and looking at tumor microenvironment, it seems like gemcitabine, which we are trying to promote the uptake of, is making things worse in terms of suppressing the suppressive environment. And we may actually be better off without it. And interestingly, pulsed HIFU alone and cavitation caused by it, by itself reduces PD-L1 expression paradoxically in the tumor, which is something that we have recently found. With gemcitabine, that effect is not as pronounced. So it'll be interesting to look at that further. But yeah, one thing I wanted to point out is in terms of pancreas, at least, there's this one big thing with penetration. If things don't penetrate, like you can throw whatever at it, it's not going to do much.
Yeah, thanks. And in the presentation of Dr. Farah, I don't know, Cathy, if you're online, but you mentioned that the differences in immune and tumor cell distribution and the microenvironment will affect the response to HIFU based on a recent publication. So I don't know if you're here, can you comment on that, on your findings? Okay, Cathy is not here. And in terms of breast, if you go back to the discussion about breast cancer, Tim, if you're here, could you comment on this immunosuppressive? So we discussed the importance of let's say, counterbalancing the immunosuppressive microenvironment in combination with thermal ablation. Is it something that you think should be aimed in more general across tumors, or do you think it's specific to the breast?
It's a bit of a loaded question. So I can contextualize it with a couple of mouse models. So the 41 model, which Cathy commented on earlier, has not been a great model. She's absolutely right about that in terms of it's just so overloaded with granulocytic MDSCs. It's not really consistent with the patient setting, except from the fact it's a really immunosuppressed environment. It's not responsive to anti-PD-1. And so it represents a subset of patients, even though the subgeography of the tumor, the stroma of the tumor is actually quite distinct from what most patients have. You contrast that with the EO771 model, which is a commonly used triple negative breast cancer model. that's actually quite responsive to anti-PD-1, and particularly combination therapies. And so it's not representative of the patient's setting. And the other aspect of it, but on the other hand, it has a myeloid cell representation, which is much more consistent with patients. So it's much more M2 macrophage associated, has lots of regulatory T cells in it. And so you're in this sort of paradox here of, do you use the model that reflects the patient's response to immune therapy, or do you then use the model that's not necessarily reflective, but has more of the myeloid cell components? And so I think you need to pick the model to answer the question you're most important for the question you're asking. So let's say you want to understand with the focused ultrasound, how's it affecting that very early, almost the innate acute response to the thermal damage or the mechanical damage. What are the myeloid cells doing in the first 6 hours? Well, you want the model that represents what the appropriate myeloid composition of the tumor that is most similar to the patient. You don't want the granulocytic one. But if you want to understand a model that is now going to promote responsiveness to anti-PD-1, maybe the 41 or another non-traditionally responsive model is appropriate. I think the other thing to bear in mind is as we start getting clinical experience with some of the trials we started, we will be beginning to understand how the patient's tumors respond to sonication. As you know, we're doing a clinical trial where we're sequencing anti-PD-1 with thermal ablation in breast cancer. We're beginning to learn from the RNA-seq data that comes out of that, differences in the patient's setup, differences in how they respond writ large at the moment, because we haven't progressed far enough to break the identity of the patients by treatment arm. But we're going to be able to do that and say, okay, this is what focused ultrasound looks like in a breast cancer patient, or in terms of response. Which of the mouse models actually replicate that most accurately? And then we should really think about having a consensus movement to using those mouse models in our community. And obviously, we've touched on metastatic disease, we've touched on fibrosis representation in pancreatic cancer. We started off the conversation about glioblastoma. I mean, do we have a decent model that represents glioblastoma that doesn't involve putting a needle in the brain that then disrupts the meninges, and et cetera? Do we really move to some of the genetic models that truly are devoid of immune cells, but then they take months to do? So there's compromises that have to be made. So in the breast cancer model, go to sort of encapsulate what I just said, I think you need to choose the model that is addressing the hypothesis that you are testing most accurately.
Dr. Guha?
No, I think, very inspiring answer by team, because, so we all are kind of equating breast in a mouse equals breast in a human. That's not ever going to be possible. In genetic models, maybe I have asked a question that, let's say, KPC model, the KRAS P53 has some, so I can ask those type of questions, but the antigenic burden, everything is different between a KPC model and a human pancreas and so forth. So my suggestion is, team, you bring this up. So I am asking the whole group as a whole that we all have our several cell lines we work on. And we know, for example, 41 is a very consistent model which secretes GCSF and has myeloid-derived suppressor cells. We know that. So can we lump different cell lines, which we all are using, into a classification of mechanisms of resistance? For example, as Tim said, 41 equals wound healing with GCSF, MDSC, blah, blah, blah. Any other model where regulatory T cells plays a role, we highlight it. Any model where carcinoma-associated fibroblast plays a role, we highlight it. Because if we, instead of thinking anatomy, if we classify the model system, because unless you are doing orthotopic injection all the time, most of us are just using the mechanisms by which that tumor cell line grows. And so I think I second what Tim was suggesting, that the question, what you are asking, defines the model rather than we trying to think anatomy defines it, because most of these cell lines, do not represent, the real clinic. And especially Ashish, Dr. Ranjan was mentioning about the abscopal effects. Abscopal effects are very difficult in transplantation models, where you have a cell line. It's probably the best I have seen is from Kathy's department, when they use the PYMT breast cancer model with already pre-existing breast nodules. Now you are treating one and seeing the disappearance. This is the OX40 paper with CPG oligos and radiation and so forth. So yeah, that I believe, but otherwise I think let's try to classify the cell line according to the mechanism and then ask that question. So if your question is that, does ultrasound stimulate myeloid infiltration? So you take a less myeloid versus a high myeloid and see the difference. Or if your question is, does ultrasound treatment overcome PD-1 resistance? Yeah, 41 would be a great model to study that. So I just wanted to second that. That was a great idea, team. And maybe we can all join hands together to see what different cell lines we have with what mechanism of resistance.
Yeah, thank you. Thanks a lot. I see that Kathy is here. I asked a question. We just have a few minutes left, and I will try to keep 5 minutes to wrap up and discuss future projects. But you discussed in your presentation the impact of tumor cell distribution and microenvironment on the response in your recent paper. If you could give us just a brief overview of what you found in this regard.
Yeah, I'm not sure of your exact question in terms of the effect of the model on response or the effect of different treatments.
Yeah, the effect of the model on the response.
Yeah. I guess what I was trying to express earlier was, some of the surprises that we saw when, in comparing, for example, the NDL, which is a breast tumor epithelial model, that we didn't anticipate how different the cytokines would be compared to, for example, pancreatic cancer, for example, to KPC. So, I definitely support the idea that having a set of models where that there is some specific feature is a really good thing to try to tease apart. But also, I think that some of the engineered mouse models that are very similar to, or at least thought to be very similar to human cancers, may give some surprises as well, in that there can be very significant differences in the biology compared to, say, for example, 4T1 or some of the other cell lines that we're used to working with. I'm not sure that I answered your question, or if I got.
I think we got we have 5 minutes left. So the 5 last minutes, we can discuss what what the foundation can bring or support in terms of next step, next action. So obviously, the points raised by Tim, Chandan, and Kathy about trying to lead the effort to propose a list and of all the models we are available in our groups and their specific features is one thing. And I think it's also links to a discussion that we had, a suggestion by Dr. Shu previously of trying to list also the different data that we have in terms of successes or failures, and if we can specifically point to treatment regimens and what biologics were assessed. So now, in terms of research projects, for example, what do you think would be the most exciting. Is it, for example, to tackle a specific question, let's say a resistance to PD-1, and compare different modalities? Or should we pick a model resistant to PD-1 for a specific type of tumor, let's say breast, and tackle it with a specific modality, HIFU, because HIFU is already used in breast cancer. So what do you think we should be doing? So what?
Yes.
What would you like us to
It's huge. Yeah, it's huge.
No, I know. But yeah,
I mean, I think one of the things that came out from earlier discussion, the first thing was this sort of how does histotripsy versus thermal ablation, how is it received by the tumor microenvironment and perceived by the tumor microenvironment? So you take a disease like breast cancer, you pick the right model. There's a lot of conversation about the relative merits of histotripsy in terms of antigen maintenance potentially, but also the concerns about lymphatic disruption. How is each of these modalities received, and how consistently is that initial response generated in that tumor microenvironment? So where I'm going with this is there in fact a very consistent innate response to histotripsy in the same, and how different is it to thermal ablation at the same time points in the same model? Can we start benchmarking some information, and how much variation is really coming according to a particular institution's delivery system, the transducers, etc.? I mean, you can benchmark elements of temperature engagement in the area of temperature impact. You can presumably do something very similar of histotripsy because it's a very well demarked area. But if you then do a consistent RNA-seq, a series of RNA-seq experiments, you're now beginning to understand how acute and more durable initial responses are different between the modalities. And once you have that knowledge and we start getting data out of patients, we'll have some ability to co-localize those data sets to say, okay, now we've got the right model, we've got the right, you understand the strengths and the weaknesses in terms of the innate response that we think will parlay into an adaptive response. And I think we really need this sort of studies, which unfortunately federal agencies don't like to fund because they're very incremental in a way, and then they're very progressive. They're almost like engineering approaches to doing it. It's not necessarily hypothesis driven. And when you build that knowledge, then you have a much clearer picture of how different regimens are going to affect the environment. And that then sets you up, if a patient comes in with a certain setup, what is the right regimen for that patient? That's my 2 cents at the moment.
Go ahead, Katie.
Yeah, I guess I might add, I was really impressed with what Teresa had to say earlier as well, that in terms of that they're really reading out from some of their other human studies, a set of parameters that, a complicated set of parameters, but a set of parameters that they think may be predictive of outcome. I wonder if we could learn from that set and come up with a set of measurements that we should all be making and make those same measurements. Yeah, I guess that's one thing I think. The other is our lab has taken more the view that we really want to be integrated with immunotherapy approaches, and that especially for a thermal ablation, we think that you need to prime first because we think the effects are so fast that you have to have the right immune environment and you have to modulate your immune environment before you come in. So it just another dimensionality in terms of what do you add first and then what do you do afterwards. So I think that's the other hard question. So we definitely need a set of consistent parameters that we measure, and it would be really great to be informed by other human studies in immunotherapy as to what those parameters might be.
Yeah, and so we have to close the session, but I think we can go back to this discussion maybe tomorrow afternoon if you're available for the discussion on our immuno guidelines and let's say biomarker immune assessments tomorrow afternoon. So thanks everybody. I think we have 30 minutes lunch break, and we'll resume at 12:35. Thank you very much.